A pediatric patient arrives in the examination room with a severely antalgic gait or a total refusal to bear weight on one leg. This presentation forces an immediate clinical decision. The patient is experiencing either a benign, self-limiting mimic or an irreversible, joint-destroying catastrophe. Differentiating these two outcomes does not rely on clinical intuition. It requires applying rigid, mathematically defined thresholds to the patient's data. The first diagnostic vector is synovial sepsis, a state where bacterial enzymatic destruction rapidly dissolves articular cartilage. The second vector is idiopathic ischemia, an asymptomatic vascular dropout that silently starves the bone of its blood supply. The third vector is mechanical shear, where acute physical stress fractures and displaces the growth plate. Mastering the specific demographic markers and pathophysiologic mechanics of these three vectors is the only way to prevent permanent structural disability in the pediatric hip. Septic arthritis is a time-sensitive surgical emergency. There is no window for observation. To identify this emergency, we rely on an absolute diagnostic threshold, the Kocher criteria. The first two criteria are clinical: inability to bear weight, and a core temperature strictly greater than 38.5 degrees Celsius. The final two are laboratory markers: an erythrocyte sedimentation rate over 40 and a white blood cell count exceeding 12,000. If a patient satisfies 3 or 4 of these criteria, the mathematical probability of a septic joint exceeds 90%. Breaching that 90% threshold strictly mandates an immediate, ultrasound-guided aspiration of the joint fluid. This text excerpt defines the absolute laboratory threshold for synovial sepsis, purulent synovial fluid yielding greater than 50,000 white blood cells per cubic millimeter, with Staphylococcus aureus as the primary culprit. Breaking this 50,000 cell count limit dictates an emergent surgical washout. Without it, the bacterial enzymes will cause rapid, irreversible destruction of the joint cartilage. We must contrast this destructive emergency with its primary differential, transient synovitis, a post-viral mimic. Transient synovitis specifically targets children aged 3 to 8 years old, almost always following a recent viral upper respiratory infection. The presentation is distinct. The child has a mild limp and a benign joint effusion, but completely lacks the high fever and severe inflammatory markers characteristic of sepsis. Septic arthritis is a destructive, febrile emergency requiring the operating room. Transient synovitis is a benign, afebrile inflammation managed safely with observation and NSAIDs. Unlike infectious destruction, we now look at structural starvation. This drives Legg-Calvé-Perthes disease, the idiopathic avascular necrosis of the proximal femoral epiphysis. The demographic target for this disease is strictly isolated: young boys, specifically between 4 and 8 years old. The clinical signature of the disease is insidious. The child develops a chronic, painless limp or a mild, intermittent ache that fluctuates over weeks. Unlike septic arthritis, Legg-Calvé-Perthes completely lacks fevers, systemic signs of illness, or elevated inflammatory markers. This leads directly into a radiographic trap. Early plain X-rays of the hip in these patients frequently appear completely normal. Because early X-rays fail to capture the initial vascular loss, a magnetic resonance imaging scan is strictly required for early definitive diagnosis. If the diagnosis is missed, the late-stage radiographic progression is severe. The starved femoral head collapses, becoming dense, flattened, and irreversibly fragmented. Missing the early asymptomatic ischemic window ensures permanent structural deformity, ultimately requiring intensive bracing and casting to maintain the containment of the femoral head. Unlike slow ischemia, mechanical shear is an acute physical failure. This defines slipped capital femoral epiphysis, or SFE, where the proximal femoral epiphysis displaces. The demographic for this failure is highly specific: overwhelmingly obese males experiencing the rapid adolescent growth spurt, specifically between 10 and 14 years old. To diagnose SFE at the bedside, clinicians rely on a pathognomonic physical exam finding. Passively flexing the patient's hips straight up mechanically forces the thigh to visibly roll outward into external rotation. This forced rotation is not a muscle spasm. It is a direct physical consequence of the altered geometry of the sheared growth plate. This radiograph demonstrates the definitive evidence. The displaced femoral head sits off the metaphysis, resembling ice cream sliding off a cone. The immediate clinical mandate is absolute non-weight-bearing status. Bearing weight threatens catastrophic disruption of the remaining vascular supply. Leg calvae perthes is a slow ischemic event in young boys. Slipped capital femoral epiphysis is an acute mechanical emergency in obese adolescents that mandates immediate surgical pinning in situ. We can test the integration of these 3 vectors using a single high-stakes master clinical case. The patient is a 13-year-old male with a BMI in the 98th percentile. His chief complaint is a 2-week history of a dull, aching pain in his right knee. The negative findings are critical here. He strictly denies any recent trauma, he denies any hip pain, and he has 0 fever or systemic symptoms. The physical exam of the knee sets the clinical trap. It is perfectly normal. There is no effusion, his ligaments are intact, the McMurray test is negative, and radiographs of the knee show absolutely no abnormalities. This exact presentation heavily tempts clinicians into misdiagnosing a benign pediatric issue, like Osgood-Schlatter disease or patellofemoral syndrome. This brings us to the assessment execution question. What is the most appropriate next step in management? We immediately eliminate all local knee interventions, no knee MRI, no reassurance, and no joint aspiration. Bypassing local knee diagnostics is absolutely mandatory when the physical exam of that joint is entirely normal. We also eliminate systemic testing for inflammatory markers. The complete lack of fever and the insidious 2-week timeline point away from synovial sepsis. The correct diagnostic pathway requires the clinician to forcefully step back and order bilateral AP and frog leg lateral X-rays of the pelvis. The pathophysiologic mechanism hiding this diagnosis is referred pain. A signal originates from the distressed hip joint, travels down the obturator nerve, and terminates precisely at the medial aspect of the knee. Because of the obturator nerve's specific anatomical pathway, a mechanically sheared femoral epiphysis will frequently present entirely as isolated knee pain. This leaves us with a hard clinical rule. An isolated, non-traumatic knee pain in the adolescent demographic must be assumed to be referred pain from the hip until proven otherwise.